Hello and welcome to MD Newsline. Please introduce yourself to our audience.
Thank you for having me. It's such a pleasure being here today. My name is Dr. Lisel M. I'm an associate professor of medicine at SUNY Downstate, an endocrinologist. I work at SUNY Downstate Kings County Hospital, and I'm also a consultant at Susan Smith McKinney Nursing and Rehab Facility.
Great. So tell me a little bit about your experience at the conference so far. What has stood out to you the most?
So, many of the lectures are just wonderful, very insightful, informative. But the two that really stood out to me the most are one, the hybrid insulin pump management. It's stood out to me because, of course, it involves diabetes, which is one of the very important diseases that we deal with, very common. 537 million people are diagnosed with diabetes, and that's estimated to go up to over 700 million in the next 20 years or so. So it's definitely a very important disease. I have patients on the insulin pump, and I had the opportunity to ask questions about a particular patient, pregnant patient with diabetes that I was concerned about. I learned about just a combination and comparing the different types of insulin pump. I use the MiniMed Medtronic 780G most commonly, but I also was able to learn about how it compares to the Omnipod 5 and some other newer pumps that are coming out, like the Twilight and even Control IQ. So just cutting edge information that was learned here I think would be very helpful in applying that to my patients with diabetes, which is such a common disease and affects, so many people in significant ways.
Mm-hmm. What are some of the challenges that you face most often with patients with gestational diabetes that you've been seeing in practice?
Just poor control. So the patient that I have is a young patient, and I've seen, young women who present in the first or even second trimester, even sometimes in the third trimester of pregnancy, and with poorly controlled diabetes. It's something that is very important in the management of pregnant patients because it affects the fetus significantly. It can lead to large babies, so large for gestational age children, that can lead to shoulder dystocia and difficulties during delivery. So, and just overall management of diabetic pregnant patients is important for not only the mother, but the fetus as well.
Mm-hmm. So what are the current screening recommendations for pregnant women for gestational diabetes, and when should those typically occur?
Right. So usually it should occur in a high-risk population. It should occur early, before 28 weeks gestation. And high-risk populations are women that have a past history of gestational diabetes, certain populations like African American populations, and other populations like Native American populations as well, obese patients with obesity. So those patients should have screening glucose tolerance tests early in pregnancy.
Mm-hmm. Can you explain the difference between the one-step and two-step screening approaches for gestational diabetes, and is there one process that you prefer over another?
So we usually get the patients after they've been screened and are found to be diabetic. But yeah, there's the 75-gram oral glucose tolerance test and the 50-gram oral glucose tolerance test as well. And we also add the hemoglobin A1C, which is being used more and more, and it's more important in addition to the oral glucose tolerance test in these patients.
The patients coming to you once they've already been diagnosed, what state are these patients usually in? Is there usually maybe like an incident that happens that kind of forces them into your office, or
Right. So many of these patients have been following up with the OBGYN, and maybe on screening they've been found to have high sugars, or they were admitted to the hospital for high sugars found on routine exam or maybe symptomatic. But most of them are usually referred from the OBGYN because of screening hyperglycemia.
What are some of the first steps that you typically take with a patient when they come into your office?
Right. So the most important initial step is just talking to patients about nutrition. So having good nutritional management, decreasing the amount of carbohydrates and sugars in the diet, and also controlling the portions is key in management of diabetes, whether pregnant or not. But definitely in pregnancy, strict nutritional management is a first step in controlling diabetes. After that, then there's some medications that are used during pregnancy that are not accessible or being able to be used during pregnancy because they're dangerous to the fetus. So just making sure that they're not on those medications that are dangerous to the fetus, and then really focusing on insulin management in some of these patients. So many of the patients who have gestational diabetes are managed on insulin.
Do you ever have to work with patients that are on GLP-1s, and how does that impact your work?
Right. So for pregnant patients, first of all, should not be on GLP-1s. But yes, I definitely work with many patients, non-pregnant patients who are on GLP-1s. And we have a lot. So what are the indications for GLP-1? Of course, a patient that's poorly controlled and obese, usually with a BMI greater than 30. So these patients should be started on GLP-1 as long as they have no contraindications. Some of the contraindications include poor renal control, so poor kidney management, poor kidney disease. So I actually work with many patients that I recommend GLP-1s to help not only manage their blood sugars, but also control their weight. And it's been very, very helpful in managing their diabetes and with weight loss. I think one of the things, the instances that I encounter are just deciding on which GLP-1 we should use in the patient, and also making sure that the GLP-1 that I choose is covered by the patient's insurance.
Yeah. With their popularity and with, pregnancy not always being planned,
Right.
I can't help but wonder if there's some people who end up pregnant while they're on them, and then what the protocol for that might be.
Right. So the protocol is just stopping it as soon as they find out they're pregnant, stopping it immediately and replacing it with a medication that is safe in pregnancy, such as in some instances metformin or a sulfonylurea, or definitely insulin. So, to be proactive, women who are of childbearing age, we usually recommend that, they not be put on it, especially if they're trying to become pregnant. So it's definitely important to be proactive, in our practice with looking at patients who might become pregnant and making sure that we manage them appropriately so that risk does not happen. But yes, if it does happen, we definitely stop the medications and switch to a medication that definitely is safe in pregnancy.
Are there any kind of complications with the transition from a GLP-1 to another one of those medications, especially if the patient's already pregnant? Like, how does that transition occur?
Yeah, the risk is hyperglycemia. So definitely, knowing what is the equivalent dose of the new medication to put this patient on. And this is not always very clear. So yes, I think the key is really close follow-up. So what I do is, I would stop this, whatever, if the patient is on a GLP-1 and pregnant, stop that medication, and definitely not just rely on diet, right? Because they are on a medication that was needed to control their sugars. So I would definitely go to either insulin or another medication that is safe in pregnancy.
Speaking of diet, what blood glucose targets do you typically recommend for women with gestational diabetes before and after meals?
Okay, so fasting blood sugar should be less than 95 in pregnant women. And definitely that's something that we strictly adhere to. And postprandial blood sugars should be no higher than 120 milligrams per deciliter.
And what is the process of monitoring the health of the mom and the baby in this case, and how often are we doing that?
Right. So for me, if the patient, so all pregnant patients that come to me with gestational diabetes, I see them at least once a month during their pregnancy. If their control is poor, uh, meaning very poorly controlled, I would see them maybe in 2 weeks after the initial visit to make sure that their diabetes is better controlled than it was when they initially presented to my office.
And then how are we working with the OB to kind of create? Is there a kind of like a birth plan, and what's the process with that to get us kind of across the bridge to a successful delivery?
Right. So they really just rely on us to keep those sugars under control within the recommended guidelines of less than 95 and less than 122 hours postprandially. But we work with the OB to make sure that there are no other issues or concerns in addition to the diabetes that we need to address during the pregnancy.
And does this kind of impact the timing or method of delivery often, do you find?
Well, if the sugars are controlled, no. But if they're poorly controlled, then it may, because the patient may be at risk of more complications. So patients, however, patients who do have poor control and have large for gestational age babies are at higher risk of needing a C-section. So yes, in that way, it definitely can affect the pregnancy and delivery.
So once we have a successful delivery, what's your approach to kind of postpartum care for patients who have had gestational diabetes?
Right. So for patients who've had gestational diabetes, the first question I ask them postpartum is whether they're breastfeeding or not, because many of the medications that may not be safe in pregnancy may also not be safe in breastfeeding. So, so if they are breastfeeding, again, I can make sure that I'm controlling their diabetes with medications that are safe during lactation. And if they're not breastfeeding, then actually, although many of them may improve after delivery, so they may not need as much medications for diabetes to begin with, and whatever medications they do need, if they're not breastfeeding, then I can put them maybe back on some of the medications that they had been on before if they were diabetic prior to pregnancy.
And what is the likelihood of persistent diabetes after pregnancy, and how are we kind of follow up and screening for that?
Right. So there are several different presentations. So a patient may present who had diabetes, obviously prior to pregnancy, which is pregestational diabetes, and of course that will continue usually after pregnancy. But patients who are diagnosed during pregnancy with gestational diabetes, many times it resolves. However, the patient is at higher risk of recurrent diabetes within 5 years. So we definitely need to monitor those patients closely because their risk of getting diabetes, type 2 diabetes, is higher.
Are there any misconceptions that you find that patients often come in with who are already diagnosed with gestational diabetes, and how do you address those?
Yeah, maybe some of the misconceptions are that once they deliver, they don't have to worry about their diet anymore because they don't have diabetes anymore and it was only during the pregnancy, which can be true, but they would need to understand that the risk of developing recurrent diabetes is higher than if they never had gestational diabetes.
And I'm thinking about the way that the hormones of pregnancy postpartum kind of impact women. You have things
Right.
like postpartum depression. We just had,
Right.
earlier conversation about how, hypoglycemia might impact mood and things like that.
Right.
How does a patient having either diabetes or just gestational diabetes impact those kind of post-pregnancy hormones?
Well, in terms of the insulin hormone, again, it improves after delivery because pregnancy is a very highly insulin resistant state. So once patients deliver, their hormones, they're less insulin resistant and their diabetes is better controlled. In terms of mood and others, maybe psychiatric diagnoses, that's diabetes does put you at increased risk of depression. However, the patients that are high risk are patients with diabetes, and usually postpartum it resolves. So I would think that improves postpartum. Actually, that kind of leads me into one of the other topics that was interesting at this conference, and it was the thyroid related topics. So the challenging cases in thyroid cancer was very a great presentation that I really enjoyed. But in relation to thyroid and pregnancy, patients who deliver are at higher risk may have postpartum thyroiditis. So that is one thing that can also affect the mood. So they can have postpartum hyperthyroidism, where they're at a heightened metabolic state, and then hypothyroidism, and then it resolves. So that is an area of postpartum treatment that needs to be evaluated and monitored closely.
Yeah. Tell me more about this presentation.
Yes.
What about it really stood out to you as far as other insights, if any?
Right. So challenging cases in thyroid cancer. Thyroid cancer is another area that I am very interested in. And again, epidemiologically, there 2.2% of new cancer cases are thyroid related. So that's important. And over 44,000 there are over 44,000 new cases of thyroid cancer a year. So that is, definitely a rising statistic. And recently, in recent years, the risk of thyroid cancer and prevalence of thyroid cancer is rising. Incidence and prevalence of thyroid cancer is rising. So it is, again, a very common disease, just like diabetes. So we have very complicated cases of thyroid cancer that I really make an effort to try to manage well. So that is a area of interest for me, and to be able to talk to the experts in thyroid cancer about how to manage those challenging cases and hear how they relate those challenging cases to the guidelines and how they integrate that was very helpful and very insightful. I was able to attend that conference today, and it was actually very interesting to me. And I actually was able to ask questions at the end of the lecture that I will apply specifically to my practice.
Mm-hmm. What makes the cases of thyroid cancer more complicated, in your opinion? What are some of the things that are affected by it?
Right. So thyroid cancer can be treated straightforwardly if the thyroid cancer is diagnosed, treated surgically. So the management of thyroid cancer involves identification of the cancer, usually by biopsy or fine needle aspiration of a thyroid nodule. And once it's found to be cancerous, the cancer is removed surgically. The whole thyroid, the entire thyroid is usually removed. So then the question would be, is this patient low, intermediate, or high risk? And should they be treated with radioactive iodine or not? Or can they just be treated with the usual follow-up with just surgery and TSH suppression with levothyroxine, and follow-up with ultrasound and thyroglobulin levels? So the challenge comes in when maybe the patient may be between low to intermediate risk, and deciding whether this patient needs radioactive iodine or not. Or a patient who may be high risk, and we're treating them with radioactive iodine, and then also adding medication. They may have metastatic disease, and we may treat them with a tyrosine kinase inhibitor, and they're still not responsive to those optimal medications and modalities of treatment. So those are the more challenging cases, and knowing how to manage those cases is definitely key in helping with the resolution and treatment.
Are there some patient populations or other factors that make people more likely to not respond to like the kinase inhibitors, or are there any trends that you've observed or are aware?
Well, the people that have late diagnosis, that are diagnosed late with severely, significantly a metastatic disease, thyroid cancer is very slow growing, and it is a treatable cancer. So unlike some of the other cancers, thyroid cancer in general is very responsive to treatment. So when we have a patient that is not responsive to treatment or may have undifferentiated disease that is not responsive to radioactive iodine treatment, it's unusual. And what patients that are at risk trends, maybe I think patients that really present with late metastatic disease. And by that time, although we optimize the treatment, they may not be treatable. I do also have a master's in public health, so I am interested in population medicine and managing diseases like thyroid disease and diabetes, not only on an individual level, one-to-one with the patient, but also I'm interested in, population health as well. And so that question is definitely important and dear to me as well.
When I think about just thyroid disease in general, I think about I think I read a paper somewhere recently that the thyroid can increase your likelihood to have adverse medication reactions, because there's so many, the way that it impacts your hormones, maybe your stress levels and things like that. Right. From a public health perspective, there's some people deal with more high chronic stress than others, which might increase your likelihood of having maybe a thyroid issue. What are some of your thoughts on that, and maybe what can be done from a GP level to screen for this? Because although it's slow growing, the symptoms, the major symptoms might not present until later. So right. Where are the gaps in diagnosis, and what are your thoughts on like how different populations that experience maybe stress at different levels might be better served?
So the stress-related aspects of thyroid disease may be more related less to thyroid cancer, but more to hyperthyroidism, like Graves' disease or toxic multinodular goiters. So patients can be screened for Graves' disease or even hypothyroidism, which is also called Hashimoto's disease. So Graves' disease is hyperthyroidism, an overactive thyroid, an increased metabolism. Hashimoto's disease is an underactive thyroid, resulting in a decreased metabolism. Patients that are at risk for these diseases are patients with a family history. So Graves' disease can be genetically inherited. So patients who have a family history of Graves' disease definitely can present with symptoms of anxiety and other symptoms that of increased metabolism, but the more psycho or neurologic symptoms can be anxiety, maybe just frustration, and depression. So yes, it definitely can affect, and stress can bring some of those symptoms out if they are already at higher risk of getting them. So definitely.
Once someone goes through the process of treating thyroid cancer, I'm guessing like a thyroidectomy would probably be typical.
Yes, usually total thyroidectomy. And in some cases, in some intermediate and high-risk patients, radioactive iodine treatment as well, and suppression of their thyroid-stimulating hormone, which is from the pituitary. So basically, there is a thyroid-stimulating hormone that's released from the pituitary gland that can stimulate the thyroid gland itself. Once you remove the thyroid gland, if there's usually maybe some residual tissue there, just because the surgeon can get every little cell. So the thyroid stimulating hormone can increase the activity of those cells. And if you suppress it, it decreases the risk of that happening.
And then once a thyroidectomy happens, now we have to be on medication or something. So
Right.
what is kind of the cascading effect of having a thyroidectomy, and what type of maybe complications or kind of challenges does that introduce in the patient's life and health overall moving forward?
That's a great question. Thank you. So once the patient has had a thyroidectomy, they have to be on lifelong thyroid hormone replacement. And that includes usually some form of levothyroxine. I've used Synthroid in the past, but there are other forms of levothyroxine hormone replacement, and that is needed. So thyroid hormone is necessary for life. So we replace them with thyroid hormone. Usually we calculate it as 1.6 milligrams per kilogram as a standard starting dose. So they have thyroid hormone replacement, and then they have to be followed with an ultrasound annually of the thyroid and a thyroglobulin level.
When patients have to now be on kind of these lifelong medications after they've had a total thyroidectomy, are these patients typically in a certain age group? And if they are younger, how does that factor into things like maybe pregnancy over time or other significant life events?
Right. So that's very important. So again, patients with thyroid cancer can range from, a younger age to older age. Patients with thyroid disease, the average age is like hyper or hypothyroidism is 40 to 60 years old. But if a patient has a total thyroidectomy and a woman of childbearing age needs levothyroxine replacement, usually during pregnancy, they will need higher doses of thyroid hormone, usually 1/3 higher, because there's something called the thyroid binding globulin, which is the globulin that binds thyroid hormone. It increases during pregnancy. So the amount of free hormone available in the blood is less because more of it is bound during pregnancy. So yeah, they would need higher doses to have higher free hormone levels.
Interesting. Wow, this has been a great conversation. Thank you so much for taking the time to chat with us. Is there anything that we haven't covered, or do you have any parting words for fellow healthcare providers?
Yeah, just that, I think it is important to attend these annual conferences, just to kind of, in addition to keeping updated by reading journals, just coming in an environment where you're able to interact with experts and other people in your area of specialty is very needed and very important. So I would encourage people to continue to do that on an annual basis as often as you can.
Thanks for joining us on MD Newsline. This has been an amazing conversation.